I'm Dr. K. Wang, a close friend of Dr. Joing, who nicely established this videotaping facility in an attempt to disseminate medical information throughout the world. I really owe him a lot allowing me to do this. Today we are going to share some interesting radiographic findings with you. These are the collections that I made throughout my career. Let's look at the first X-ray. This is a chest X-ray, undoubtedly. At a first glance, one would say, wow, such a marked cardiomegaly. But is it really? Ordinarily, the cardiac silhouette should come in, not splaying out. On this side too, it should come in rather than splaying out. And besides, if you look at carefully, there's a double density here. Actually, the heart is this, and this is all something else. And what's that something else? This patient had a CT of the chest. Are you surprised? Fat underneath the subcutaneous fat, substernal fat, fat underneath the epicardium. The heart is this one. This is the heart. So these are all fat. But fat and tissue do not have any different radial density, so on plain chest X-ray, you may not be able to recognize it until you do a CT scan of the chest. But already, as I mentioned, the shape of the cardiac silhouette will tell you that this is not all heart. This is from another patient. A very interesting finding of lumbar spine. If you just showed me this one spine here, without hesitation, I would have said osteolytic lesion from malignancy. But look at the curvature here. So what's causing this erosion of the lumbar vertebrae? What's in front of the lumbar vertebrae? Aorta. So this is actually AAA causing erosion of the lumbar vertebrae. Remember, we are supposed to look for rib notching in coarctation. In coarctation, the increased intercostal arteries will bound against the rib, lower margin of the rib, causing pressure necrosis or erosion. And that's what rib notching is in coarctation. So same thing is happening here. AAA pounding against the lumbar spine, say 70 or 80 times per minute for many years, will result in pressure necrosis or erosion like this. So this is actually AAA causing findings like this. What do you see behind the heart or within the cardiac silhouette? There's an air fluid level here. Air and fluid, air fluid level. You cannot have anything that has air fluid level in the heart. So what's this? This is a structure behind the heart. On the lateral view, there is a clear air fluid level in the herniated stomach, a good diagnostic example of hiatal hernia. This is an interesting patient that I dealt with a while ago. This patient came to me with a dyspnea on exertion. And story tells me that it is a cardiac because she has no anemia or chest problems or chest deformity or lung problems. So there was no other reason for her to have dyspnea. So it is a cardiac. So I have to find the cause of dyspnea in this patient. And I examined carefully, and there was no particular cardiac findings, no murmurs, gallops, clicks, or opening snap or rumble. Very quiet. I went down to the X-ray department. I couldn't believe what I was seeing. This is a picture of mitral stenosis. What I mean by that is that there's a double density here, which is a reflection of an enlarged left atrium. And as you know, there should be aortic knob, then pulmonic knob, then it should be concave, then ventricular bulging. Here there's an additional knob, aortic knob, pulmonic knob, then additional knob. What is this? That's the enlarged left atrial appendage. Additionally, there's a curly B lines here, and the costophrenic angle is blunted, and a slight cephalization of the vasculature in the lungs. The left ventricle is spared. So what could cause enlarged left atrium, left atrial appendage, curly B lines reflecting increased left atrial pressure, and some degree of congestive heart failure? It had to be mitral stenosis. So I couldn't believe that I missed the physical diagnosis of an obvious case of mitral stenosis. I went up to the floor, listened carefully, looking for mitral stenosis, but still there were no physical findings of mitral stenosis. There's a such thing as a silent mitral stenosis, when the mitral stenosis is very severe, decreasing the cardiac output so much so that there isn't much of a flow across, then you may not hear any murmurs or opening snap or anything. So I had to do 5 sit-ups, and she was somehow able to do it, and listened again carefully, and still I didn't hear anything. So it occurred to me, oh, maybe I'm mistaken about the X-ray findings. So went down to the X-ray department again and looked at the X-ray, and there's no mistake about it. So what could I be dealing with? Of course, the X-ray is not telling me that I have mitral stenosis. What the X-ray is telling me is that there's an obstruction at the mitral level with the enlarged left atrium, left atrial appendage, increased pressure causing curly B lines, and some congestive heart failure causing pleural effusion. So what could obstruct the mitral valve level without mitral stenosis? And it occurred to me that maybe I'm dealing with a left atrial myxoma. So remember, we order echocardiogram. I don't know what I'm dealing with, echocardiogram. But here I was able to order echocardiogram with the rule out left atrial myxoma. And indeed, the echo showed the left atrial myxoma, and patient was taken to the operating room. Look what was found. This is a 7 cm big left atrial myxoma. The surgeons couldn't believe how the patient was living. Blood must be trickled around this big left atrial myxoma. So just the X-ray findings allowed me to make the diagnosis in the absence of physical findings. What do we see here? Air in the biliary tree. After sphincterotomy, many patients will have air in the stomach going into biliary tree, pneumobilia. Another patient with a pneumobilia. So this patient must have had sphincterotomy, and the sphincter is widely open. Another case of pneumobilia. But how about this one? There is air in the liver bed, but not like a tree branching out like a pneumobilia. This is actually air in the portal venous system in the liver. So what is it diagnostic of? Massive bowel infarction. Supposedly, with the massive bowel infarction, the oxygen released from oxyhemoglobin due to low PO2 is causing this air in the liver. Diagnostic of massive bowel infarction. From another patient, you can appreciate that the fine network of air, not as clear as the previous case, but this again is another case of massive bowel infarction with the air in the portal venous system. This big bulge is actually dilated pulmonary trunk, and it may be reflection of a primary pulmonary hypertension, or like in this patient, the caliber of the pulmonary artery right and left is too big, and another example of a manifestation of a pulmonary hypertension. This patient too has a markedly enlarged left and right pulmonary artery, including some congestion. This patient may have had congenital heart disease with a pulmonary hypertension. What do we see in this patient? There's a nodular density here which tend to cavitate. Nodular density there which tend to cavitate. Multiple of them. From another patient, nodular density there which tend to cavitate. What are these? Septic pulmonary emboli. Actually, this is a sort of an abscess in a patient with a right-sided infective endocarditis. So infection on the tricuspid valve, vegetation breaks off, goes to the lungs, trapped in the lung, building a sharp here, and they will cavitate because it is a small abscess here. So when you see these multiple nodules which tend to cavitate, like here or here, this is a diagnostic of right-sided infective endocarditis. This is a fluid loculated in the minor fissure, and this hazy density is a fluid loculated in the major fissure as findings of or manifestation of congestive heart failure. And you can appreciate that fluid in the minor fissure and the fluid in the major fissure, manifestation of a congestive heart failure. This is a fluid accumulated in the major fissure, looking like this in this patient. And on the lateral view, you don't see it very well, but that loculated fluid in the major fissure is here. Fluid in the minor fissure. Now, what are we dealing with here? Here's a left hemidiaphragm. Is this a right hemidiaphragm? And something underneath the diaphragm? Or is this something else? The costophrenic angle is sharply maintained, so one is less likely to think of a pleural effusion, but this is actually pleural effusion. Since it behaves differently, we have to call it differently. We call it subpulmonic effusion. That is, a lung is floating on top of the fluid, and actually the diaphragm is down here. So we can appreciate that because one side of the quote diaphragm is higher than the other, so it will raise us to ask what's happening. What if it is on the left side? Well, it will be easier to recognize because the air bubble in the stomach will be way down here, while what appears to be diaphragm is here. It is not even loculated because it freely layers out. So subpulmonic effusion. We call it differently because the costophrenic angle is sharply maintained. So lung is sort of floating on top of the fluid. How about this patient? Is this elevated right and left hemidiaphragm? Well, the gas bubble in the stomach is way down here. The distance from here to here is unaccounted for. Actually, diaphragm is here. This is all fluid. So this is a bilateral subpulmonic effusion as a manifestation of a congestive heart failure in this patient. I cannot explain why some patients maintain sharp costophrenic angle while many others will have either meniscus or blunting of the costophrenic angle. Just to allow you to appreciate how normally the gas bubble in the stomach and the diaphragm is located, well, this is the lateral X-ray of that same patient, again allowing us to appreciate the gas bubble in the stomach is here, while diaphragm should be right above it, but this is all fluid subpulmonic effusion. To allow you to appreciate the relationship between the left hemidiaphragm and the gas bubble in the stomach, I picked this normal person, gas bubble in the stomach. This is the way it should be. On the lateral view, see how the left hemidiaphragm will hug around the gas bubble in the stomach. And that's the normal relationship. So diaphragm should be right above the gas bubble in the stomach. If there's too much of a space unaccounted for, you may be dealing with a subpulmonic effusion. Is this atelectasis of left lung? But if you look at carefully, there's a lung markings going beyond. If it is atelectasis, lung markings shouldn't go there. Lung markings are there, so lungs are not collapsed. So what are we dealing with then? Well, this is from another patient with a CT scan of the chest who had unilateral pleural effusion. If this patient had a supine X-ray, where X-ray beam goes from here to here, no wonder then one side of the lung will be almost opacified or densely white like this, making us think of atelectasis. So this is when you see the lung markings go beyond, there's no collapse of the lung. This is a unilateral pleural effusion with the X-ray taken in supine position, mimicking massive atelectasis of the left lung. This is not as severe as the other one, but again, unilateral haziness or increased density, but lung markings go beyond. So this patient has a unilateral pleural effusion on the right side now, and X-ray taken in supine position will manifest like this. There's a line here, and there's no lung markings here. Some may call this a pneumothorax. Here's a line here too. But on this side, the lung markings go beyond. What are we dealing with? This is a skin fold. This is a skin fold simulating, especially up here where there's no lung markings. Some may call this a pneumothorax, while actually it is just a skin fold. Why no lung markings here? This patient must have a bullous emphysema affecting more of the left upper lung. Can you make the diagnosis? And a very important one too. The finding is here. There's a double line. The cardiac silhouette should have just a single line, no double line. This is a pneumomediastinum. I know it's subtle, but if you look at carefully, we cannot ignore the fact that there's a double line. So this is a pneumomediastinum. I hope you will pick it up if it happens to you when you are on call. Well, this patient, the findings are not subtle. Pneumomediastinum with a subcutaneous emphysema extending all the way to the neck. So pneumomediastinum, sometimes it could be as subtle as this, but again, the double line is the clue here. This patient is in obvious congestive heart failure with a pulmonary congestion here and good example of a curly B lines. This patient too has curly B lines, but there's no congestion. This is a lymphatics loaded with a malignancy. Lymphangitic spread of malignancy here, while previous one was fluid in the minor lymphatics causing curly B lines, and this is a malignant cell filling the lymphatics, looking like a curly B lines, but it's a lymphangitic spread of a malignancy. You can tell that because there's no cephalization and no pulmonary congestion, not like this one. There's obvious pulmonary edema here, and this is a curly B lines as a manifestation of a heart failure, while this is a malignancy affecting the lymphatics. This patient has infiltration of the lung affecting here and here. You can draw sort of a vertical line, affected, not affected. And this vertical line doesn't conform with any lung anatomy, such as upper lobe, middle lobe, or lower lobe. What could affect the tissue inside of this vertical line spreading outside? Not as clear as here, but again, inside of this vertical line, not affecting outside of this vertical line. Well, this patient underwent radiation treatment. So this outer area is a shielded area, and the radiation is targeted this area. So radiation-induced pneumonitis, you can make the diagnosis from this almost imaginary vertical line spreading the tissue outside, affecting the tissue only inside, both here as well as here. What's this bulge? This is an ascending aorta bulging out in a patient with aortic valvular stenosis. So we'll call this a post-stenotic dilation of the ascending aorta. In aortic stenosis,
The ventricle may be thick, but if it is not dilated, the ventricular size may not be enlarged. While in aortic regurgitation, it's a volume overload lesion, so that the left ventricle will be displayed downward and to the left. So you can appreciate by the shape of the cardiac silhouette, this is massive aortic regurgitation, while this could be tight aortic valvular stenosis, and the heart may weigh 2-3 times of normal, but if it is not dilated, you will have not enlarged cardiac silhouette, not like this one. How about this one? Aortic knob, pulmonic knob, and it should be concave, but there's an additional bulge. As I said before, this is an enlarged left atrial appendage doing it, and the left ventricle is not enlarged. So mitral stenosis can do this. Or it can straighten out the left cardiac border. Instead of aortic knob, pulmonic knob, and concave, and so on, or aortic knob and pulmonic knob and another bulge, it may just straighten out. So this is another way how mitral stenosis will manifest. This one has a double density here, reflecting enlarged left atrium, bulge here, reflecting dilated left atrial appendage. Then there's a combination of left ventricular enlargement. So this will be the picture of combined mitral stenosis and insufficiency. Nowadays, we don't let patients go this far, so you may not encounter chest X-ray silhouette looking like this. But in the olden days, yes, this will be typical combined mitral stenosis and insufficiency. And this will be more or less pure mitral stenosis, pure mitral stenosis. So you can tell them apart. Is this a right heart border? Actually, this is an example of a thymoma, substernal thymoma, looking like enlarged right atrium. This one is truly markedly enlarged right atrium. It's literally touching the right chest cage. So markedly enlarged right atrium. This patient must have a severe tricuspid regurgitation from whatever cause. Thank you for your attention.